Good afternoon, everybody. We are Sweetwater Regional Cancer Center. My name is Lacey Reddick, and I will be presenting for our team. And we want to share with you our project, Improving the Feeding Tube Placement Process for Head and Neck Radiation Oncology Patients. A brief institutional overview about our site. We are located in Rock Springs, Wyoming, and we are considered a frontier cancer center, which serves over a 100-mile radius. And to give you a little idea about our size, which is pertinent to our project, radiation oncology sees approximately 81 new patients a year. 17 of those are head and neck patients, and that includes those who do not need a feeding tube. And for the purpose of our project, we are using head and neck in a very broad sense of the definition, which could also include esophageal patients. Here are our team members. And then because we can't be there in person, we did prepare a video for everybody to see just about reflections on our QTP experience, if I can share that with you now.
My name is Josie Ibarra, and I'm a registered dietitian.
I am Patty Olexi, and I am the Director of Education and Employee Health.
My name is Eva Wasim. I'm the Radiation Oncology Nurse.
My name is Lacey Reddick, and I'm the Clinical Trials Facilitator.
I felt excited and clueless.
I felt very apprehensive. I wasn't sure what to expect.
I was a little bit anxious.
I felt maybe a little overwhelmed.
I think I learned that we have to slow down a little bit and we have to be a little bit more methodical about how we try to solve problems.
As we did our process plan, the thing that we thought was the obvious problem was not the obvious problem.
I really enjoyed learning about how to analyze the data.
My favorite part was to work through the root of the problem, through the fishbone, as we kept it process-based and not human error-based.
I think my favorite part was seeing some of the results and using some of the interventions and then interviewing our patients and getting their feedback. I feel like that's the most meaningful thing is when it affects the patient care and it affects their experience.
I feel like the project was very successful because I feel like we were trying to work on this before, but we were going in many directions. So having this clear plan, this process plan, helped us all stay on the same track.
I'm mostly proud of the team.
I'm proud of our team coming together and working together and not pointing fingers at others.
I'm grateful for Coach Ashraf.
I think I'm most proud of the teamwork that we developed. We are Memorial Hospital of Sweetwater County, compassionate care
for every life we touch.
Thank you for letting us share that with you guys. So the problem we wanted to focus on for this class, this QTP class, is written here. I'll read it to you guys verbatim. Between January 1st of 2021 and May 31st of 2023, 7 newly diagnosed head and neck cancer patients in radiation oncology at Memorial Hospital, Sweetwater County, required feeding tubes to safely receive effective radiation therapy. 71% of these patients had 3 or more rework loops, or deviations, within the feeding tube placement process, which led to patient and staff frustration, delayed discharge after feeding tube placement, interrupted radiation treatment, and increased cost. In the next slides, I want to talk more about what we mean by rework loops, and then why did we decide on 3 or more as being unacceptable. So this is what we chose to do to measure for our outcome measure. So we chose to measure the percentage of patients with 3 or more rework loops within the feeding tube placement process. And then the next slide, I can explain a little bit better by what I mean by rework loops and how did we gather data to measure this. So this is our process map before any of our changes. To briefly explain the rework loops and how we gathered our data, the white symbols that you see in this process map are the pathway that we expected the patient to take in getting their feeding tube, or what we thought was happening. So it starts with the patient's diagnosis at the very beginning, and then it takes the patient through the process of getting their feeding tubes placed and back to us for radiation therapy treatment. Anytime the patient had an issue causing a full stop in this process, and then we as staff had to scramble to figure out how to solve that problem and get them back on the path to their feeding tubes, we would consider this a rework loop or deviation. And you see those identified here in orange. We tried only to focus on process issues and not medically caused issues. And in the end, we identified 18 rework loops. That did not mean that every patient hit every rework loop, but that there were 18 potential deviations a patient could experience. We took each patient and our baseline sample population and we passed them through this map and we counted how many rework loops or orange boxes did they hit, or in other words, how many times did each of those patients deviate from the process. And what we discovered in the end was a lot of waste, and no two patients have the same pathway. And this indicated to us that it wasn't that our process was broken, it was that we really had no process to begin with. So after we passed our baseline sample population through this map, we counted the number of rework loops each had, and then we ended up with our baseline outcome measure, which you see charted here. This chart is just showing the number of rework loops per patient. And in the end, we had a median, which was also the average of 3 rework loops per patient. And further analyzing this chart, we discovered that 71% of our patients had 3 or more rework loops. So based off of this, this median, this chart, and our process map, we decided that 3 or more rework loops per patient was excessive and unreasonable. We can never prevent rework loops completely, but we can certainly try to minimize them if they're due to process issues. So after we analyzed our baseline data, it helped us develop our aim statement and figure out what was a reasonable goal for us. So we aimed to decrease the percentage of patients who experience 3 or more rework loops or deviations in the feeding tube placement process from 71% to less than 50% at Memorial Hospital of Sweetwater County by December 1st of 2023. From our aim statement, we moved on to our cause and effect diagram. We now know our patients are experiencing a high number of rework loops in our process, but what is causing these rework loops? So our cause and effect diagram here, at the head of the fishbone, we have our ultimate problem, multiple rework loops in our feeding tube placement process. And then all the little bones underneath that are the issues that are leading to those multiple rework loops. So this is a lot to take in. This is very busy. So how do we know what problems to focus on for our first PDSA cycles? So what we did is we identified the root causes to all of those issues, all those little bones that led to the multiple rework loops. And then we categorized those root causes. We ended up with 7 categories for the root causes, and then we counted how many times does each root cause appear on this graph, this fishbone here. And this led us to our Pareto chart, which is a little more easier to digest than all of this. So here's our Pareto chart. This chart is showing the number of occurrences the root cause categories appeared in our feeding tube placement process. So for example, policy issue appeared 25 times on our cause and effect diagram. Education issue appeared 17 times, so on and so forth. So when we did our cumulative percentage, we hit the 80% a little after those top 3 categories that you see highlighted in yellow. And this told us that these were the things we wanted to focus on for our first PDSA cycles. So we wanted to focus on our policy issues. These could be things like simply a lack of policy, or things, a lack of things you would find in a policy, such as role assignments, a standard, process maps, things like that. Also, education issues. This could be the education of our staff, just educating our staff on the process and their place in it, but also the education of the patient. Are we educating them at the same time? Are we being consistent in their education? And then also we wanted to focus on our communication issues, such as communication issues between departments or between department and patient. So now that we know what we want to focus on, what is our action plan? We were able to complete 2 PDSA cycles for this project. And our first cycle was for the intervention for our first cycle was simply just to create a process. And that's the intervention on its own. But we also knew that we wanted 4 pivotal elements in our process map that we wanted to track as interventions in their own right. And you see those listed here on this table. But ultimately, the biggest takeaway from this slide is that our intervention was to simplify our process map with clear role assignments and more defined expectations and timeframes for each of these items found in our new process map. And to give you an idea of what these little additional 4 interventions here, the first one is basically just dictating who and when to send like home health and nutrition formula orders. The second one is assigning patient education to staff roles and dictating when for it to completed, which we wanted it to be completed before surgery. And I mean educating the patient in this sense. The third one is assigning to the rad-onc RN to send the dietitian referral within a week of the rad-onc consult, so that the dietitian could be much more notified of the patient early on. And then the fourth one is assigning to the rad-onc RN to notify case management about the patient and all the things that we've completed before surgery, so they're also in the loop. So then that led us to our new process map. So you see our processes before and after side by side. And I apologize how small these are, but I really hope that this shows the outcome from our first PDSA cycle, which is that we created a process with well-defined roles, which is the color coding you see there on the right. And I really think that we improved our valued added, valued enabled, and waste. We decreased our rework loops from 18 to 4. So creating a process was our first step to our aim. So how did we do following our new process map? And we analyzed our next set of patient data to our new process map. We essentially did the same thing we did with our baseline data. We would take our next set of patient data and pass them through this process map and see how well we followed this process map. And specifically, we really wanted to track those 4 interventions that I kind of went into a little bit of detail in that previous slide. And these graphs are kind of showing how well we did. So what these graphs are showing is, are we doing the tasks or interventions we said we would do in our new process map? And we measured them as met or not met. And after we defined each task in more detail, who would complete them and when to complete them within our new process map, we saw an improvement in all interventions. But we also learned where we already need to improve in some of these interventions, which we're already addressing in our currently in progress cycle 3. Also, during this cycle 1, we interviewed patients. The patient voice is super important to us. We don't want to lose that in our project. And so we're asking patients to share their experience, and their feedback and suggestions will be used as we further develop our process. So now that we're figuring out what is working in our new process, we moved on to our PDSA cycle 2. And so for the intervention for PDSA cycle 2, we wanted to educate others on the process. Specifically, we assigned to the education department to educate the general surgery clinic staff about the new process and their responsibilities in it. And then going forward, we will educate any pertinent staff roles at the time of new hire and require an annual competency. So after we complete that intervention, we have our results here in this run chart. And this chart is showing the competency scores for the staff pre and post intervention. And the intervention here is being us educating that those staff members. And we did see an improvement in their competency scores. So we've gone through our cycles 1, our cycles 2, and we made all these changes with good intentions. But are we unintentionally causing negative changes with the staff? And specifically, are we affecting the staff's satisfaction or morale within this process? And that's what we chose to map for our balance measure. So this graph is showing the staff satisfaction scores pre and post our PDSA cycles. So before our PDSA cycles, we had an average satisfaction score of an 8.2. And then after our PDSA cycles, we had an average satisfaction score of 11.6. So we saw an increase, which is exciting. But if you are kind of looking at this chart a little bit more in depth, you will notice that we had some staff roles that measured higher before the PDSA cycles and lower after, meaning not everybody was happy with the changes we made. But that's to be expected. Change is really hard, especially when we're really changing and adding on to things we're expecting these staff to do. So we will continue to reassess this, we'll look for trends, and then also talk to those staff members that maybe are scoring lower than we hoped and see what we can do to make this process better for them and not cause them any unnecessary stress. We made it through our cycle 1 and cycle 2. We've implemented these changes in the hopes that it will help minimize patients experiencing rework loops or deviations in the whole process. So how did we do in reaching our aim? And as a reminder, we aimed to decrease the percentage of patients who experience 3 or more rework loops from 71% to less than 50%. And here is our outcome. So again, this run chart is just showing the number of rework loops per patient. Before our PDSA cycle, we had a mean of 3 rework loops per patient. And after our PDSA cycle, we actually had a mean of 1 rework loop per patient. And then further analyzing this chart, we discovered we decreased from 71% to 0% of our patients that had 3 or more rework loops. We don't want to get overly excited by this because obviously we don't have a lot of data to show any kind of trend, but it is exciting for our group because it's just encouraging us and showing us that we might be on the right path. So what next? Where do we go from here? Of course, we want to keep sustainability in the back of our minds, and these are the items we want to use to create and maintain sustainability. Of course, we have our process map. We're further defining that, further refining it, and this is defining roles and expectations within the process. We've created a checklist, which we actually started in our currently in progress cycle 3, and this is a way for us to standardize the process to make sure we are following the process map with every patient every time. We're utilizing our EMR more. So this is enhancing accessibility to documentation, which which includes that checklist, and also improving communication between departments. And we have that education piece I talked about previously. We're educating all staff involved in the process at time of hiring and requiring annual competencies. And then, of course, our ultimate end game is going to be a policy, which will include all these items as well as our process map. And here is our current in process cycle 3 process map. Like I said, we're just trying to keep refining this process and simplifying as best we can. You can see the color coding a little better on this one, showing our role assignments. And also, I hope you are noticing that there are no orange boxes, trying to eliminate that waste as much as possible and avoid any kind of deviations the patient might experience. So that's all I have for everybody. I really appreciate your time. If you have any questions or comments for us, please don't hesitate to contact us using that contact information below. Thanks, everybody.